He used this method in 17 children and 24 feet with mean age of 3.9 years. However, he modified what he proposed, that abduction cannot be achieved till 70 degrees in most of these children. So he obtained a minimum abduction of 30 degrees and he used AFO instead of foot abduction brace. What he observed was 66% success rate, and he commented that's a simple, effective and inexpensive method, especially for these older children. Now, Monica et al. From Brazil in 2009 applied this Ponseti method in recurrent club foot, especially which had failed posterior release in 83 feet with mean age of 5.2 years and average follow-up of 45 months. And what she found, a success rate of 86%. And she again commented that Ponseti technique has a role in these feet, especially recurring after the posterior release. Now, a large series from the Nepal in which they use this method in 260 feet, but the age group was little less, varied from 1 year to 6 years. With a mean of 7 casts, they could avoid surgery in 94% of children. And they again proposed that Ponseti technique has a role in walking children up to the age of 6 years. Now the last reference shown by Dr. Alam also, that he went further in children older than 7 years in 25 feet with mean age of 8.9 years, and with a long follow-up, he reported 85% success rate. And he again commented that it should be the initial modality and it's a cost-effective tool, especially for physicians working in a resource challenge environment like ours. So, we, encouraged by these reviews and by our own results, we did a prospective study from March to December 2012, in which we included 43 feet, the age group was 2 to 11 years, with mean age of 4.1 years. Now, the follow-up was 28 months. We excluded non-idiopathic or syndromic cases from our study. Now, we classified this deformity based on the treatment received into neglected, in which the child has received little or no treatment in the past, or relapse, having received some form of treatment, either surgical release or supposed Ponseti casting. Again, these children, this is important, were further classified on clinical examination based on the intrinsic flexibility and reducibility of the foot, irrespective of the age or the previous treatment taken, into moderately flexible, moderately stiff and rigid. A moderately flexible feet implies the deformity can be corrected into one or more plane, whereas moderately stiff or minimal flexible feet implies that deformity has some correctability but not to neutral position with moderate deformity persisting, whereas a rigid feet implies that there is no correction possible in any plane. So our assessment included again the Pirani scoring, 6-point Pirani scoring, which it actually is not a very good classification system for these older children, but we used as a surrogate to assess the severity of the deformity. And goniometric assessment of ankle dorsiflexion, heel varus and forefoot adduction were also done before and after completion of the treatment. Counseling and consent, actually these are the important elements, especially in these older children, were the essential part of our treatment protocol. And to optimize correction in these older children, we modified Ponseti method. It remained in principle, but with some minor modifications, which were cast change at every 2 weeks to allow soft cartilaginous bones to remodel sufficiently and tissues to stretch instead of the regular 1-week Ponseti method. We added percutaneous plantar fascia release in 54% of the feet, especially in those feet with rigid and recalcitrant cavus, which were not responding to the Ponseti alone. The feet were again maximally abducted, but to tell you that these feet cannot be abducted up to 70 degrees in every child. So they were maximally abducted, which varied from 30 to 60 degrees. Percutaneous T8 tenotomy was done in 84% of the feet. And bracing schedule was also modified, since it is very difficult to reinforce full-time bracing, which was 16 to 18 hours for the first 3 months, followed by nighttime bracing, depending on the age of the child. And our criteria of the good result was normal looking plantigrade foot with straight medial and lateral borders which allows normal shoe wear. And the failure actually means the need for open surgical release with or without osteotomy. So based on these criteria, we achieved 76% correction, that is good clinical correction in 76% of the feet. And when we saw that it was 100% in moderately flexible, 82% in moderately stiff, however it was low, 40% in rigid type of feet. And the average number of casts were 9.4. Now, to see the effect of age, we found that clinical correction was better in children less than 5 years, and it naturally dropped after the age of 5 years to 60%. And the failure rate was 24%, that is 10 out of 43 feet, which required open releases with or without bony surgeries. And there was one neglected case and 9 were relapsed, which were mainly due to past surgical intervention. There were few recurrences such as cavus, forefoot adduction and dynamic supination in 2 children each. Now few case example.
You'll have to sum up.
Now just hurrying fast. This 4-year-old boy had a good clinical correction after 8 cast, and you can see there is even radiological correction. And sorry. Now he's walking normally with normal foot progression angle. Just move forward. Another girl, a bigger, older child. Now when she presented, she was referred for surgical releases. And after 12 cast, one can see there is not only clinical but as well as good radiological correction. And fortunately, this poor girl has started going to school for the first time in her life. And what I could see that she is wearing the same dress even after the 6 months. Now this is the oldest child in which we use this method. And when she presented to us, she was actually limping. She had infected bursa on the lateral aspect. But we still persisted with, we explained her and we followed her with Ponseti casting. And you see, after 6.5 months, same child, she is walking normally, she is pain-free. So these are some other examples in which we could get good results. Now, Ponseti method basically relies on the principle of biological plasticity and remodeling. And this helps to reshape the bones by activation of circumferential physis, even in these older children. Now, this is similar to the principle, that is distraction principle or the tension stress principle of the Ilizarov, which helps to reshape the bones. The minor surgical procedures such as plantar fascia releases and tenotomies are joint sparing surgeries with no adverse effect. Now what is important to remember that even in an older child there is a spectrum of severity, and in spite of the age or negligence, some of these feet retain the flexibility and reducibility which respond very favorably to the Ponseti method, as seen in our own series. That clinical correction was 80 to 100% in moderately flexible and stiff feet. So the degree of intrinsic flexibility is an important determinant for the success, or I would say even for the failure of Ponseti method, irrespective of the age or any previous treatment taken. So I do acknowledge, yes sir, the last slide, the few limitations such as small sample size and the follow-up, and there's a need for reliable scoring system as well as brace for these older children. But in spite of these constraints, I think the doctors working in the developing world should use this method even in an older child, because it's easy, effective, efficient, as well as economical. And I was privileged enough to be invited to present as a paper in this recently concluded AOS in March in Chicago. So thank you and enjoy casting.
Dr. Vikas, you have taken 10 minutes. So I would like Dr. Gangwal to please come on the podium, and please wind up your talk in 5 minutes.
Well, thank you, Dr. Sood, Dr. Varghese. Just going ahead with the discussion on the clubfoot, operative versus casting. And I think if somebody asks what's the role of surgery in clubfoot, I think this is a group where surgery may be indicated. Well, the foot itself, whether neglected, recurrent, relapsed, or residual, is definitely deformed. The deformity is rigid, it is severe, there are callosities, and there are often accompanying bony deformities. The child is ambulatory, it's hard to keep him off the bed, uncontrollable and often uncooperative. The family, they just want the deformity corrected. That's what they're there for. Quicker is better for them, surer is better. They don't want recurrences, they don't want repeated visits, and money is always an issue with them. Well, the setting then is a child with a severe deformity, is ambulatory, difficult to control. The family is already disillusioned. They want the job done quickly and surely. Surgery has always been the standard of soft tissue. The standard has been a soft tissue release in these older children. It can be tailored as per needs. Foot osteotomies can be added for correction of deformity, and the procedure is quick and fairly straightforward. The surgery has been the standard of care in these children. It's time tested, results are fairly predictable, and it's a one-shot remedy. Well, here we can see an older child and deformed feet, one stage soft tissue release with the lateral column shortening, and feet are corrected, and there is sufficient mobility in the foot. Biggest problem with casting for clubfoot, it's hard to convince the parents. You have to just keep talking to them and telling them that, this is better. They're just not willing to believe you. Hard to control the child. They have repeated visits, and there's no clear end in sight. And it's like it's hard to convince a monkey that strawberries are sweeter than bananas. Casting the older child, the treatment is prolonged. It's difficult to keep the child on the bed and non-weight bearing, and it's very time consuming. It's labor intensive. You need to stretch for 5 to 10 minutes each time. And here we get tired stretching 1 minute in the small child. You have to use above knee casts, and the child, it's impossible to keep him off the bed, and they will break them. And casting actually is more prolonged in these children because it takes more time for the soft tissues to relax. So you have to change it once in 2 weeks, which prolongs the duration of treatment. If we say casting is not costly, we have to think again. You have to factor in travel, you have to factor in cast material costs also. Outcomes are less predictable as compared to surgery. They require prolonged bracing, and the child will not tolerate the foot abduction brace, which essentially is the reason why these small children perform so well after the Ponsardi technique. And that's why a significant number will require a second surgical intervention. Further downsides, there are some complications, though they are uncommon. Pressure sores can happen, cast breakdown, poor compliance, high chances of fallout, and they require a prolonged follow-up. Well, comparing outcomes, deformity correction, I think eventually both groups, the deformity will get corrected. Range of motion is comparable, and cost again is comparable. Recurrences higher probably in the casting group, in this age group. Bracing is always a big issue, and duration of treatment is much longer. Surgical risk, complications, and scarring are obviously non-existent in the casting group, as they're having no surgery. So just for comparison, the cast is difficult for the child, it's difficult for the family, and it's also difficult for the surgeon. Surgery is easier for the child, it's one shot, easier for the family, they don't have to stay there for long, and surgeons are always happier operating. So just consensus statement, cast milder deformities, cast for adductus and varus, get some correction with a formal posterior release. For more severe deformities, you can perform a formal soft tissue surgery and add osteotomies as required for complete correction. And distraction with an external fixator may be a useful method in this situation. Thank you.
Thank you, Dr. Kapil. I think we now have a discussion on this. Can I invite all the speakers here? In this house, people that are sitting, how many of you are doing Ponsardi for the older child? For the older child. And how many of it is operating for any age group? I think for any age group, the numbers are very low compared to the conservative ones.
It's monkeys versus humans. and strawberries are actually not sweeter than bananas.
Okay, questions from the audience?
Dr. Espidas, my question to Dr. Sahalam. All the recent advances you discussed, accepted, but giving up for the non-orthopedics personnel at this moment is not acceptable because we know the teachings and acceptance of this method to non-orthopedic surgeons. So 2 papers you have shown, that is in Western literatures, but we should not give up this to this at this moment in India.
Not give up surgery.
No, non-orthopedic surgeons, plaster techniques.
Non-orthopedic surgeons.
Well, that's debatable. We are not debating that, but what the stress was that it's such a simple method that it can even be used by the non-orthopedic surgeon. And I think it's high time that we be a little more benevolent than what we are. We have to train our physiotherapists, we have to train our nurses to at least apply a plaster. If you can train them putting injections all over the place, sticking in needles in the sciatic nerve, why can't you train them to put a simple cast?
The physiotherapists were involved in the management of clubfoot in Uganda. The whole country had 8 orthopedic surgeons. They had no choice. But they found using physiotherapists was as effective as using the orthopedic surgeons. That is the message. The method is so simple. But the learning curve for a surgical procedure is long. The learning curve for Ponson's technique, if you follow it meticulously, if you try to modify it, you're in for trouble. But if you follow it meticulously, it is a good method for these patients.
Sir, to teach the plaster technique is fine, but certain cases need surgery, certain cases need, say, as discussed, other methods also. So I think...
No, I'm not saying, sir, I'm not saying that you send the patient right away to a physiotherapist, no.
Yes.
The thing is, they have to be involved in the program. You have approximately 20,000 children born with clubfoot.
The estimates for the country is 50,000 children born with clubfoot in India.
The orthopedic population cannot take care of them. That's for sure. So you have to involve the ancillary support system, and that includes physiotherapists, your nurses, your plaster technicians. You have to involve that. We're not saying that you stop doing and they will do, or they are free to do whatever they're like running amok. No, they have to be part of the final care of clubfoot, and that includes giving them independence even in applying plasters. That is the essence.
And to Dr. Vikas Gupta, suppose 10 to 12 plasters you apply for a neglected clubfoot.
Excuse me, sir. Could you repeat it?
You apply 10 to 12 plasters to a neglected clubfoot to correct it by Ponson's method. Yeah. But whether it is really cost effective?
Definitely, sir, cost effective. The children were very happy and...
No, not happiness, not correction. Or
cost effective.
Cost effective.
In terms of what?
Suppose a patient comes for plaster with their mother or father of that child of that age, the work loss. So around 500 to 1,000 rupees for the patient and family. And again, plaster and personnel in the hospital. So you calculate one-time surgery is better or the 10 to 12 time plaster, cost effectiveness of the program we are telling.
Okay,
I'm asking that.
Yeah. In terms of the cost of the things required, they are supplied free in all the government hospitals. So they were not paying for anything other than coming to the hospital. Now regarding, like in the first visit, I'm coming. Regarding the wage loss, these children were brought by the mother themselves. Only during the first visit, when we counsel them, we tell them the total duration, approximate duration, which can vary from 3 months to 6 months. And we give them the choice. And truly, no one opted for surgical releases considering the complications and the complexity associated with it. And the father usually accompanied the child during the counseling session. And after that, we never had any problem of they were very cooperative in terms of coming to the hospital every 2 weeks.
In the hospital, even plaster is free, surgery is also free.
Yeah, everything is supplied free.
Anyone else to ask? Yeah, Dr. Thani.
Right, we really don't know. I mean, I've done it till 12. Dr. Methani wants to say something. Yeah, absolutely. That's
my oldest patient was 11 years, sir.
That's the evolution.
I am using it in 14 years.
Sir wants.
We don't know. The upper age limit is when the structural changes have happened, then you do not get the results that you expect from Ponson's. That is the issue. How much of structural changes happened in the bones? That determines your endpoint.
Flexibility.
No, the X-ray changes are there.
I don't. Sir, we don't take X-ray. We don't take MRIs in these kids. X-rays, yes, if there is a flat top talus, maybe you will have difficulty dorsiflexing. That's all. Yes, there are degenerative changes which even in the presence of which you can actually correct the foot. So that's what we want to prove, that you can correct the foot even in the presence of those degenerative changes. Slight. They're never remarkable degenerative changes as you see in an adult.
Even sir, the X-ray I showed you, actually, they are the telltale sign that even I was surprised to see the amount of remodeling which we can achieve in some of these children.
Dr. Mehtani? The international opinion, there is still no consensus on the upper age limit as yet. However, the international consensus is, in terms of papers that are there, the long-term results of Ponseti is far better than the long-term results of surgical treatment. Short-term results of surgery are good, but long-term results are not good. There are enough papers on that. Use the mic, no? Thank you for putting it strongly.
And sir looks after, for those who don't know, he looks after the world's largest clubfoot clinic. That's what I'm being told.
Yeah, I would like to add a comment upon the upper age limit, as you were asking, sir. I think it all depends upon the acceptance of the deformity by the child. Now, the child is very much comfortable with the deformity after he has crossed the teenage. It is in the adolescence and the teenage when he is most conscious. After that, once he starts working and he gets adapted to the occupation and to his image, he never comes back for correction. So upper age limit will be most likely adolescence. It will never be defined.
I would agree on that. Thank you. I think we need to close. Thank you very much, all the speakers and the participants in this discussion. Thank you.
Well, thank you, sir. Thank you, Dr. Matthew Verghese, Dr. Alok Sood, for that. And just a quick announcement, Delhi is going to, we were just flashing that as well on the screen, that Delhi is going to host the 2015 POSICON. And if you are interested, please go on the website and you can register now. The 2014 POSICON, Dr. Vijay Sriram was here last evening, so yesterday actually. So that is on January 10th in Chennai. So please, if you are interested in pediatric orthopedics.
Deformities and limb length discrepancies. And the first speaker in the session is Dr. Kapil Gangwal, who will be speaking on normal limb alignment in children. Dr. Kapil, please.
Well, good afternoon again. Thank you, Dr. Athani. So, just kicking off this session on, I think we got this wrong, on deformity correction and deformities in children. So, we have to first familiarize ourselves with what's normal in children. इसका slide show के ऊपर डालना पड़ेगा. Okay. So normal limb alignment in children. We have to look at torsional alignment, sagittal alignment, and the frontal alignment. We all need to know that in children there is a physiologic variation which accounts for bow legs, knock knees, in-toeing, and out-toeing. And this all changes as the child grows. We have to look at parameters for normal alignment, know what mechanical axis, anatomical axis, joint orientation angles are, and mechanical axis deviations. Well, looking at torsion, version is the normal rotational alignment of the extremity in a child. More than 2 standard deviations from this version is called torsion. Torsion can be simple, which is at one level, or it can be complex, which is at 2 levels, which may be additive to each other or compensating to each other. Rotational profile in children undergoes a change. Normally they are born with an external rotation contracture. It typically resolves by 12 months, and then children 1 in 10 will in-toe during 2 and 5 years of age. Foot progression angle is the angle the foot forms with the line of progression, and we can see that it changes as the child grows. As the torsion of the tibia and the femur changes, the foot progression angle is going to change. To measure the version, femoral anteversion, you have to draw a line along the neck of femur and the axis between and the axis it forms between the intercondylar axis. It averages about 36 degrees at birth and regresses progressively to about 15 degrees in adulthood. Children with increased femoral anteversion will typically in-toe. They trip and fall occasionally and tend to sit in the W position. To measure anteversion, clinically you can do it with the child prone by testing the internal rotation of the extremity, as you can see on the lower graph. The angle formed by the leg and the midline can give you the internal rotation at the hip. Special studies are rarely needed. You can do a CT scan or biplane radiography, but only if you are contemplating surgery. Tibial torsion typically changes from 5 degrees at birth to 15 degrees at maturity. Can be measured by constituting the thigh foot angle, which is with the child prone. You measure the angle between the foot and the thigh. Or the transmalleolar axis, in which you take the axis of the malleoli and make the angle it makes with the thigh. Coming to the knee alignment, normally in a child with the limb extended, or in a normal person with the limb extended, the condyles and the malleoli should touch. If there is a discrepancy in this, then we have to check for abnormality. You have to look for symmetry, if they are symmetric or not, and ligamentous laxity, which are the most common causes for deformity. Knee alignment changes from varus or bow-leggedness in the early childhood, and this typically resolves by about 2.5 years of age, after which the child starts going into valgus, and this stabilizes again by about 8 years of age. So the valgus will maximize at about 5 years of age and then stabilize by 8. And here we can see, you can measure the intercondylar axis, intercondylar distances and the intermalleolar distances to follow the progress of the child. To further assess the deformity, you have to get full length x-rays from pelvis to the ankle. These should be standing, and we should make sure that the pelvis is level and the patella is pointing forwards. On the x-rays, you can draw the mechanical axis, which is a line through the center of the proximal joint to the center of the distal joint, and the anatomical axis, which is a line joining mid-diaphyseal points along the axis of the bone. Then we need to know which are the joint center points. For the hip, you can use the Mohs circle, or take the diameter of the head and divide it into 2, and the point where it meets the medial edge of the femoral head, or simply use a goniometer and use the center point of that. For the distal femur, it's the apex of the intercondylar notch. For the proximal tibia, it's the midpoint between the 2 tibial spines, and for the ankle, it is the center point of the talus. Once then we need to know about joint orientation lines, and these depict the projection of the joint in the plane. And at the ankle, you join the medial and lateral points of the tibia. On the lateral, the anterior-most and the posterior-most points. On the proximal tibia, the most concave points on the tibial condyle. On the distal femur, the most convex points on the femoral condyles, and on the lateral projection, you can, I don't have that picture here, but on the lateral projection in the distal femur, the point which connects the metaphysis to the diaphysis, and in the tibia along the subchondral line. So once you have your mechanical axis, the anatomical axis, and the joint orientation lines, you can constitute some angles. And these depict the alignment of the joints. Nomenclature of these is important, and there are abbreviations for all of these. We need to be familiar with them. The joint lines on the proximal and distal aspects of the joint form the joint convergence lines angles, and the angles formed between the joint orientation lines and the mechanical and the anatomical axis form angles, and these correlate with the amount of deformity in the limb. So these are joint orientation angles on the frontal and the sagittal planes, as we can see, and looking at them more closely at the hip joint, you can draw the medial neck shaft angle, the lateral proximal femoral angle, the proximal posterior femoral angle, and the anterior neck shaft angle. And these values are important, and we need to remember them. For the knee, there's the lateral distal femoral angle and the medial proximal tibial angle, the posterior distal femoral angle, and the proximal posterior tibial angle. At the ankle, you have the LDTA, which is the lateral distal tibial angle, and the anterior distal tibial angle. Intersection points of anatomical axis to joint orientation lines can give us further information and are important for deformity planning. And you have 4 of these. There's the AJCD, which is the anatomical axis to the joint center distance. Here, the anatomical axis to the center of the hip joint you can see, and that gives you a measurement. The AJED, this is the anatomic axis to the joint edge distance. Here, the anatomical axis point of intersection with the joint line. And the distance from the anterior cortex to this intersection point gives you this value. Then you can take a ratio of the AJED with the total width of the joint, and you can take a ratio of the AJCR, which is the distance between the anatomical axis and the joint center, to the total width of the joint. And these are all values which can be noted, and these are of value when you are doing a deformity correction. Coming finally to the mechanical axis deviation, which is known to exist when you draw a line from the center point of the hip to the center point of the ankle. Normally it passes through the center of the knee joint. Now, amount of deviation of this line from the center point of the knee joint will give you an idea about the deformity of the limb. And it is a useful parameter when you are correcting deformities in extremities. Looking at it in a more simplistic manner, you can divide the knee joint into segments, and if you can see here, if the mechanical axis line passes through the first zone, your deformity is not too much, while if it goes into zone 2 or zone 3 or beyond that, then it warrants correction. I think I'll end with that and hand it to the other speakers to take this discussion further. Thank you.
The next speaker is Dr. Manoj Padman, co-chairing with me, and he'll be speaking on role of growth modulation surgery in deformity correction. Dr. Manoj.
Good afternoon again. I think this is one of the most exciting things which is, which has come up in the last probably decade ago since a lot of work by Peter Stevens, growth modulation for deformity correction. Because it's changed the way we are looking at angular deformities, especially in children, and we're needing to do lesser and lesser osteotomies, and with, no. Okay. So I just take it, I mean, it's an awkward time just after lunch, and so I just take you through as a case-based this thing. This is a 10-year-old boy with chronic kidney disease, end-stage kidney disease, urea and creatinine through the roof, and gross deformity, as you can see. And confirmed on X-rays, on standing alignment X-rays, so you can clearly see weight-bearing X-rays that the axis is way off the joint line. Okay. So, I mean, there was a time when these kind of deformities would be, it's just osteotomy. Is that the only option that you could, this thing? Now, osteotomy is certainly necessary if you have to correct rotational deformities as well as for lengthening. But angular deformities, there are much more elegant ways of addressing the same problem. So, going back to the same child, in May 2010, this is the degree of deformity. He was about 10 years old. The physis is open, you can see. And he had hemiepiphysiodesis, both at the distal femur and the proximal tibial level, and in 10 months, this is what he has achieved. Using the inherent growth potential in the physis and guiding the growth to correct the deformity. So that on the far left is the pre-op picture, and you can see post-op. So what are we talking by, what do we mean by growth modulation or guided growth? It's a reversible restraint so that you can modulate the physis, and modulate the physis, you can only inhibit the growth, you can't stimulate the growth. So therefore, reversible restraint to inhibit growth at the physis. And Peter Stevens has advocated it quite well. There's an excellent review which was published in 2006, giving you the full historical perspective of what orthopedic surgeons have historically tried to, how to influence the physis. So what are your options for growth modulation or physeal inhibition? Everyone knows the open epiphysiodesis, the femister, and the canale technique, Terry Canale's drilling of the physis. Both of them are permanent. They are not reversible. Then came Blount's staples, Metazo's transphyseal screws, percutaneous epiphysiodesis with transphyseal screws, and Peter Stevens' own 8 plates. And all these three, there are merits, pros and cons for each of them, but they are the key uniform feature is all of them are reversible, so that when you take the implant, if everything goes well, the physis should continue to grow normally. There are technical issues with staples, so staples have fell out of favor, but the other two are there. Now just briefly touching upon transphyseal screws, elegant pictures about the exact way how to do the physis. They violate the physis. So across the cross-sectional area, the two screws do not take up a lot of the cross-sectional area, but they nevertheless violate the physis, and there is potential for theoretical risk of permanent physeal damage, even though the authors would claim that it doesn't happen. But in my own hands, the practical difficulty that I find is once you put these screws, especially the femoral screws, it's very difficult to take them out. So you end up having to, you cannot, that is where the reversibility ends. You can't take it out when the correction happens because it's not easy. It gets really buried, especially the femoral screws. So I use it only towards the end of growth. So here's another child, different ages. This is a 12-year-old who had hit his adolescent growth spurt and the deformity had started to progress. So parents were concerned about it. It is not a significant deformity, as you can see this thing. It's probably just about going through the zone 2, which Dr. Kapil alluded to. But he is 12, he's 12 and a half, he's already hit his growth spurt, and the concern is that whether the physis will close, and you will be left with a situation wherein the deformity remains and you're not able to correct it. So the same pictures about the various zones. So he underwent again a distal femoral, it was a primarily femoral deformity because only the distal femoral was in valgus. You could argue that the screw on the left is probably just touching the growth plate, but it's not probably as technically put correctly as the right side, but it has done its job, as you can see, over a period of about 9 months. And one of the other things which I wanted to point out was, especially in these, when the correction happens, you can see that the the screws diverge because of the growth happening at the physis. That's an indirect, you can see correction happening. Okay, the key things like everything else, this is, patient selection, preoperative evaluation, imaging, planning, and technique, because there are different techniques available. That applies to pretty much all orthopedic surgeries. But specifically to growth modulation, what are we looking at? We need to know about what is the status of the physis. So what is the age? Sometimes you need to take a skeletal age. Etiopathology, because what is causing the deformity, and what is growth remaining. And there are several ways to check what is growth remaining. One of the simplest thing is do a lateral X-ray of the elbow and use the soft grain method as to how much growth is remaining. If it is a sick physis, it may not grow, especially if it's a post-infective or a post-traumatic deformity. If there is a physeal bar, and depending on the size and extent of the bar, you may have to resect the bar before you attempt growth modulation. And the aim of correction is to achieve a neutral mechanical axis with the ankle and knee joint lines horizontal. So here is a 4-year-old child who had an asymmetric deformity. And asymmetric deformities are difficult to cope with. He clearly had metabolic bone disease, as you can see, but the deformity is only on one side. And he again had some kidney disease, but his kidney functions were normal. Because of the asymmetric nature, he underwent a simple 8-plate epiphysiodesis. Now you could argue that if you correct the metabolic abnormality and wait for the bony deformity, that's one view. Peter Stevens would advocate that, he puts them routinely as part of this thing. I decide based on the degree of deformity, and if it is a unilateral asymmetric deformity, I'm inclined to correct it sooner. And this was put in November 2012, and over a period of about 7-8 months, the axis is restored with simple. Now, there can be situations when things are too late. There is not enough growth remaining. So this was especially in girls, you need to be careful. This was a child who had staples put in by someone else around the age of 14. And girls tend to mature fast, the physis closes. The physis is closed, the deformity is still there. As you can see, the axis is way off the mark. And she needed the plates removed and osteotomies on both sides to restore the axis. Slight bit of overcorrection to ensure that deformity does not recur. That's the pre-op and post-op clinical picture. And my final case here, this is clearly, you can see, right-sided genu valgum. She's absolutely asymptomatic. She had a history of septic arthritis, proximal tibial osteomyelitis at the age of about 1 year, and she was written off as everything all clear until she hit the adolescent growth spurt. And as you can see, she's got a clear axis deviation, but in addition to that, she has, that's the growth arrest, she has a dynamic component because of the fibrillar overgrowth, causing lateral collateral ligament laxity, distal femoral valgus, and clearly a leg-link discrepancy. So in this situation, what I wanted to illustrate was that these are the problems that she has. Now, all of it is not amenable for growth modulation. You can clearly see the zoomed up picture, clearly showing the proximal tibia and the distal femoral. This combination of deformity is quite bad for the patient because they have early degenerative changes into this thing. She presented actually with knee pain and underwent an MRI somewhere else which showed meniscal tears. That is how she presented with. And that's the degree of the deformity. She underwent, obviously, just last 2 slides. She obviously underwent the full work in terms of correction of all components of the deformity, including a distal femoral 8-plate for the valgus. So you can use 8-plate in conjunction with other modalities of treatment.
Thank you.
Okay, but what we don't know is what is the limit of correction. Is it 30 degrees? Is it 50 degrees? What are the secondary benefits are well known. It resolves ligamentous laxity. It works best on the knee because that's a fast growing. There is a rebound growth, and therefore the aim is to get slight overcorrection. It can be used around the ankle as well with screw epiphysiodesis, but works best on the knee. Thank you.
Thank you. Thank you. Now I invite Dr. Vikas Gupta to speak on innovative technique for genu valgum deformity. Dr. Vikas, I think you'll have to strictly restrict to 8 minutes,
yes,
as per the advice from the organizers.
Sure, sir.
Thank you, sir. So without wasting any time, I'm going to speak on genu valgum, correction by wedgeless femoral V-osteotomy. It's a very simple, innovative technique for which I would like to acknowledge Dr. Matthews sitting here and my residents, Dr. Amrit and Dr. Gaurav, now who are faculty members, for the data collection. Now, angular malalignments such as bow legs and knock knees are common parental concerns for which they seek specialized orthopedic advice. However, majority of these angular malalignments represent normal physiological development as shown by Selenius and Vanka in a large radiographic study. The child is born with a marked bow legs, the maximum 15 degrees, which then the knees tend to get straight, and in the subsequent 2 to 4 years, again, the child develops a physiological valgus of around 15 degrees. Hence, these children with this physiological valgus are best described as knock knees, having knock knees, not the genu valgum, in which the deformity is symmetrical and they only require observation and parental assurance. The angles when measured, the tibiofemoral angle is less than 15 degree and the intermallear distance is less than 8 centimeter in this physiological age group. On the other hand, genu valgum is a pathological valgus. It's a Latin derived term used to describe a knock knee deformity, and by definition, a child with genu valgum has tibiofemoral angle that is more than 2 standard deviation of the mean for that age. The deformity is progressive, accompanied by abnormal gait, that is medial thrust. And if you measure the angles, tibiofemoral angles are equal or more than 20 degree in the age group of 2 to 4 years when there is a physiological valgus of less than 15, and after the age of 7 years, the angle is more than 15 degree, and definitely the intermallear distance is more than 8 centimeters. And in fact, the Sherrard and Kling have outlined the criteria that if age 10 or more than that, if child has an intermallear distance 10 or more and tibiofemoral angle more than 15 degrees, he is unlikely to correct spontaneously and will require some kind of intervention, which we will see. Now, if the child remains untreated, let us see what are the consequences. With centralized mechanical axis, physis and epiphysis are shielded from abnormal stresses, which you can see. Now let's see, as the mechanical axis shifts laterally, there is a creation of the movement arm and the overloading of the lateral compartment, which can lead to early degenerative changes in the lateral as well as the anterior compartment. And according to the Volkmann law, prolonged compression over the lateral compartment will lead to relative hypoplasia of the lateral condyle of the femur, resulting in a shallow femoral sulcus, which will predispose to patellar tilt, maltracking, as well as frank dislocation. And due to abnormal thrust, medial thrust, there is a stretching or incompetency of the medial collateral ligament with progressive joint laxity as well as instability. So what are the surgical options? We all know the closing wedge, the opening wedge with release rope. So what we do, we have actually, this technique is modification of the original technique described by Aglati, in which he used this osteotomy in an osteoarthritic knee. So this is based on the principle of impaction. There are no wedges are taken and there is no opening of the lateral cortex. So this is done in supine position and with knees flexed over the bolsters. The whole limb is exposed. The incision is given in the supracondylar area, medial supracondylar area, extending from the joint line to about 8 to 10 centimeter above the adductor tubercle. The osteotomy is marked in the supracondylar area. It is V-shaped. The angle between the two limbs is around 90 degree with a shorter posterior limb. The osteotomy is initially initiated with a saw, however completed with an osteotome except the lateral cortex. Now, as you can see in this animation as well as the actual photographs, the deformity is corrected now by extending the knee and giving a gentle manual varus force. And this way that the spike, the narrower proximal cortex impacts and goes into the wider distal metaphysis. There are no wedges taken and there is no opening. The alignment is checked visually as well as by the cautery lead under image intensifier. So the V-shape allows sufficient stability and one can even manage with a high groin cast, but we can always go for internal fixation where what we use is L-shaped customized buttress plate for earlier rehabilitation or earlier mobilization. Now show you some of these cases. Now radiological assessment, as told earlier by the earlier speakers, includes standing radiograph with knee facing forward and to correct any LLD. Now it includes the anatomical tibiofemoral angle, the LDFA, that is lateral distal femoral angle, and the mechanical axis deviation. And these are the part of the malalignment test described by Pele et al. Now see this girl, 14-year-old girl with a 15 centimeter distance between the malleoli, and she was a sequelae of the rickets. Post-surgery, she has good correction and she can perform all her activities. You can see the radiological correction from 26 and 22 degree of tibiofemoral angle. She has almost normal angle, as well as the restoration of the LDFA, as well as the mechanical axis which now passes through the center of the knee joint. Another boy with more severe deformity again has full correction. Now this girl, obese girl, you can see that we opted for internal fixation. Since 2009, we are using this buttress plate. And she has good, the osteotomy remains same, but we fix this osteotomy with a L buttress shape. Another girl. So you can see that we tabulated our results in 30 limbs in which during the period 2005 to 2009, we were not using any internal fixation. And after that, in the 46 limbs, we have used this L buttress plate with mean age of 14.9 years. The period of casting remains 3 weeks with internal fixation. However, it was 8 to 10 weeks before that. The important thing is the operating time for doing this osteotomy remains as low as less than half an hour. The follow-up is 3.8 years, varying from 1 to 7 years. And when we functionally assessed these children, there was 44 out of 46 had excellent knee functional score, that is Bostman et al. Knee score. There were no major complications. However, there were deep wound infection in 2 cases which required ultimately plate removal after the osteotomy had united. And you can see that all the parameters, radiological as well as the clinical parameters are within the normal range. And when statistically analyzed, we found that it was the tibiofemoral angle pre and the post was statistically significant. So to conclude that adolescent genu valgum is not a benign entity, not merely a cosmetic deformity. It definitely leads to premature degenerative changes in the lateral as well as the patellofemoral compartment. Supracondylar femoral osteotomy is the only choice in children or after skeletal maturity. And before that, I follow that growth modulation treatment. Closing and opening wedge osteotomies, which we all have been we all know, they require specialized training as well as precise implant application, and they are full of complications. V osteotomy, which we have adapted, is easy to learn, has a short learning curve, close to the center of rotation of angulation, that is CORA, and the V shape ensures sufficient stability as well as it helps in the early union also. So to conclude, it's a very simple and cost-effective procedure, especially for those peripheral health centers with limited resources and training where they cannot afford any internal fixation device. And our results and experience with this technique have been highly satisfying. And most of my residents, those who have now gone to different places, are using this technique. Thank you.
The debate? No, that's over. Huh? That's what. Dr. Gupta is over, no? This is Dr. Gupta. Now there is a debate. Debate. Yeah. 5 minutes for this.
Okay, thank you, Dr. Athani. So, limb lengthening versus contralateral limb shortening. I think the real controversy is for the short segments, because it's more than clear that you don't want to shorten more than 5 centimeters and you don't want to lengthen if there is a discrepancy of less than 2 centimeters. So let's look at what are points in favor of doing a limb lengthening. It's more accurate, it is predictable, there is no height change, and the normal limb is left untouched. It restores normalcy, and no one likes to become short. You know, you may be tall, but you want to become taller. Family, of course, is not in favor of shortening ever, and they are less likely to tolerate any complication for the procedure that they don't like. They're well likely to tolerate a complication of lengthening, but not for shortening. It's a standardized technique now. There are fixators which we all know how to use. It's largely uncomplicated if you're doing it for a short segment. And here's a girl, she's had a femoral lengthening and she has a full range of motion and a good alignment. It allows for managing of associated deformity, as we can see. Here there is a varus with shortening, and you can manage both of these. It's well tolerated in children. They remain ambulatory. The regen rate is usually not a problem, and there is a definite endpoint. So small segment lengthening can be taken up even after skeletal maturity as a one-time procedure, and it allows for modification and correction in case there's any inaccuracy in your calculation. So there's no real timing that you have to adhere to. If the limb is about 2.5, 3 centimeters short, or let's say it reaches about 5 centimeters short, you can go ahead and lengthen, because that's the safe amount you can do in one time. You don't have to keep looking at growth charts or bone atlases or do sequential limb length measurements. Epiphysiodesis, in contrast, is a different story. You have to predict exact limb length discrepancy at maturity, which is complex. There are various methods: the Green-Anderson growth remaining charts, mostly straight line grafts, Melanus arithmetic methods, and Paley's multiplier methods. And the arithmetic is really quite mind-boggling. Inaccuracies exist in predicting exact time of skeletal maturity, predicting growth inhibition of the short limb, predicting growth remaining of the long limb. And to compound factors, you look at a 12-year girl who may have a bone age of 14 and be post-menarchal, while another one with the same age may have a bone age of 10 years and be premenarchal. So totally different growth potential. It requires prolonged planning. Charts are at best unpredictable. Limb lengths at conclusion are at best approximate. And as we can see in this recent publication, that the accuracy of current methods in determining the timing of epiphysiodesis was at best approximate. Moreover, once you do a femester or a permanent epiphysiodesis, there is no turning back. Guided growth plates, 8-plate method is not as effective as ablative procedures for correcting limb length discrepancy, and these may produce secondary deformities if the epiphysiodesis is incomplete and cause mechanical axis deviations, which have all been documented in publications. So just a consensus statement: for short segments, lengthening I think works quite well, and you can do it without getting into too much of complication. For longer segments, I think it's best appropriate to combine a lengthening with a contralateral shortening. Thank you.
Thank you, Dr. Gangwal. And now we invite Dr. Gupta to give the other side of the picture. Lengthening. Contralateral limb shortening, sorry.
Limb shortening. All right. So good afternoon, everybody. Actually, we have a debate about whether it's a limb lengthening versus contralateral limb shortening. So eventual goal remains same, whether especially in the lower limb, it's an equalization of the limb length. So it can be done with a ipsilateral limb lengthening or a contralateral limb shortening. What are the cons of ipsilateral limb lengthening? That it requires the use of Ilizarov, which many people are not familiar with. It's uncomfortable for the patient, loss of schooling because we are talking of children, and repeated follow-up, and the complications of Ilizarov, especially the complications have been listed to be as high as 200%. There is a definite risk of adjacent joint stiffness, and especially in infective and congenital conditions, adjacent joint can become subluxed or dislocated. Whereas with a contralateral limb shortening, previously which was done by an intercalary resection, that means a resection of the part and shortening of the bone, but now it is possible with a temporary or a permanent epiphysiodesis. Calculation is relatively easy by the multiplier method, and application is available on the smartphones for Apple and Android phones, where you can punch in the various parameters and you can get a calculation for a temporary epiphysiodesis or a permanent epiphysiodesis. And even in case of a temporary epiphysiodesis, you can have an idea when to remove the screw or the figure of 8 plates. The advantages are: it is minimally invasive procedure, no or minimal blood loss, no or minimal loss of school time, and patient is up and about on the second or third day and does not require the use of walking aids. No or minimal risk of stiffness if done properly, no risk of joint subluxation, and repeated follow-ups are not required as in case of Ilizarov or limb lengthening. And moreover, it's the procedure of choice where there is a pathology in a like that, where there is a hemihypertrophy of this child has a hemihypertrophy, and I think it's a procedure of choice, and a procedure of choice where there is a small amount of shortening. So what the literature says that in limb length discrepancies more than 2.5 centimeters, the complications, these patients can be basically treated with a percutaneous epiphysiodesis. And in shortening between 2 and 5 centimeters, this can be corrected easily with a contralateral epiphysiodesis. This is another paper in 1996 which they say that percutaneous epiphysiodesis is a reliable and safe and a cost-effective method, and a minimal scarring is there. In 1991, as way back in 1991, epiphysiodesis was done in 20 children of a discrepancy of about 5 centimeters, and a good result was achieved in 90% patients or more. And there are other papers, there's a long study between 1957 and 1999 where they say that they found even for cases where there was juvenile idiopathic arthritis, it was the procedure of choice where there was an unequal growth. And a recent study in rabbits, experimental study, has shown that this can be done with a radiofrequency ablation, which makes it even more minimally invasive.